the treatment of pneumonia. Treatment of pneumonia. First, you are using a severity score. Severity score is CRUB 65 score, confusion, uremia with blood urea level more than 40 milligram percentage, presence of respiratory rate more than 30 per minute, presence of low blood pressure, systolic blood pressure less than 90 per minute, and diastolic blood pressure less than 60 per minute, age more than 65. So if the score is 0 or 1, treat as OP basis. If the score is 2, treat as IP basis. If the score is 3 and above, treat as IP basis with the ICU setup. The score is somewhat obsolete because if a patient has a respiratory rate more than 30, the score may come as 1. Or if a patient has a shock as well, if the score may come as 1, you can't treat them as OP basis. So the score is obsolete. So now, treatment of pneumonia, we are starting empirical therapy without any proper antibiotic culture report available. So empirical therapy depends upon whether you are treating the patient as an OP or whether you are treating the patient as an IP. Here IV is preferable than oral. Here oral is preferable than IV therapy. In OP treatment, assess whether the patient has comorbid illness or not. If the patient has no comorbid illness, usually preferred one is monotherapy with macrolide or beta-lactam or tetracycline. Sometimes you may use combination therapy as well. Usually beta-lactam plus tetracycline is used as a combination therapy. If patient with comorbid illness, then usually use beta-lactam plus macrolide as a combination therapy or any respiratory fluoroquinolones can be used. So if patient is in IP treatment but it's a non-ICU candidate, then copy the same treatment, beta-lactam plus macrolide, but here you can give in IV therapy rather than oral. Beta-lactam IV and macrolide oral you can give to the patient, or any respiratory fluoroquinolones like levofloxacin IV can be given to the patient. If patient is in ICU setup, then beta-lactam plus macrolide or beta-lactam plus fluoroquinolone should be given to the patient. In ICU setup alone, we have some special consideration. What are the special consideration? If pseudomonas is suspected, add anti-pseudomonal penicillin. What are the anti-pseudomonal penicillins? You know, peptaz, cefepime, meropenem can be added. If MRSA is suspected, add vancomycin or linezolid to the patient. I will give an example. Like if you are choosing beta-lactam plus macrolide as a base regimen, just add vanco. This is one combination. If you are using beta-lactam plus fluoroquinolones as a base regimen, you can add linezolid also, with or without Clinda. This is one of the most preferred regimen. Okay, this is for community acquired pneumonia treatment. Next, we are going for hospital acquired pneumonia or ventilator acquired pneumonia. So, what is the definition for hospital acquired pneumonia? Occurrence of pneumonia less than 48 hours of stay in hospital. Occurrence of pneumonia after 48 to 72 hours of invasive ventilation. So this is definition. So HAP and VAP, they are shortly called. So most common organism for hospital acquired pneumonia. So we have to know about most common organism for ventilator-associated pneumonia also. They are broadly divided into early VAP and late VAP. Early VAP less than 5 days, late VAP more than 5 days. Early VAP usually common organisms like Streptococcus pneumoniae and H. influenza. Late VAP is by serious organisms like Pseudomonas, MRSA and Acinetobacter. HAP is mostly by MRSA, Pseudomonas. You prefer Pseudomonas over MRSA for common organism causing HAP. Now treatment of HAP and VAP is usually depending upon it's an MDR pathogen or a non-MDR pathogen. So they gave certain risk factors for harboring MDR pathogens. So what are the risk factors for harboring MDR pathogens? You are living or you are working in a place that has more dialysis patient with the previous history of HAP, suspect MDR in these patients, and you are actually treating a patient who has been hospitalized for more than or equal to 5 days with the history of HAP or VAP previously also, or if the patient has a sepsis or severe systemic illness. So quite a large drug history. If there is previous exposure to beta lactams or fluoroquinolones, you can suspect risk factor for MDR pathogens. They may harbor MDR pathogens in them. If patient is having non-MDR risk, then you can give beta lactam IV or respiratory fluoroquinolone IV. If the patient has MDR risk, if present, then see whether it's a patient in an ICU candidate or a non-ICU candidate. If the patient is an ICU candidate, then give ICU candidate with here both of them will be an ICU candidate without shock and with shock. If patient is without shock, then give a single gram negative coverage. That can be in beta lactam. Most preferred one is Peptas here. With or without MRSA coverage, like linezolid or vancomycin can be added according to your suspicions. If an ICU candidate, then beta lactam plus fluoroquinolones or aminoglycoside plus lining solid should be added. So this is treatment of pneumonia in a shorter span. Thank you.